really an honor to come here to participate. I'm going to try to do everything I can to be within the 7 minutes. I have no disclosures. This is where the use of mechanical circulatory support has brought us in the United States right now. As you can see, thank you so much. The number has continued to increase. We have approached 20,000 implantations over the last several years. The majority of the devices that are being placed are in green for destination therapy, bridge to candidacy in red, and bridge to transplant, which used to be a significant number, is now probably about half of the numbers that we do for devices.
You want to hold it?
I'll hold it. Thank you.
You want to switch it?
No problem. When we look at destination therapy, the devices that we use instead of transplantation, we can see that the outcome compared to the REMATCH trial in the year 2000 has continued to improve over time. And 4 years ago, the survival for destination therapy with an LVAD approaching about 75%. That number has continued to increase and improve. Now, when we compare that number with it's not going to work. Okay, it's not going to show. So, based on here it is. When we look at the success with transplantation in the United States, it's the line in red. And those numbers are, we go up now to 10, 20 years. At 5 years here, we see a survival or more of 80%. When we look at devices, when we combine all the devices together, even though I show you it had a pretty good survival rate, you can see that no matter how we put it, survival with a device, it still falls right behind transplantation. The outcome with transplantation is still much better. When we look at the issue of right ventricular dysfunction, and this is with the HeartMate 2, we know that if you have no right ventricular dysfunction after placement of an LVAD, your patient does fairly well. Or if the patient develops right ventricular failure because of it needs anotropes or needs an RVAD, a right ventricular assist device, the survival decreases. So right ventricular failure is an issue. When we look at the survival with an LVAD versus a BiVAD or even a total artificial heart, we see that the survival is less. We have thought for many years, and we have been telling people for many years, that this might have been secondary to using 2 devices as opposed to 1, or is a device technology. What we're finding with time, and I'm going to show you here, is that this might actually be because of the type of patient and the characteristic that the patient has. We have developed, and you might have used them, multiple indicators of postoperative right ventricular failure in trying to help you differentiate when you have a patient who's going to do well with an LVAD or when you have a patient who's going to develop right ventricular failure. And you can see these are 6 different indicators that use platelets, albumin, mean pressure, INR, and so on in trying to determine. And I can tell you, the reason why I show you 6 of them is because they don't work. And we have to guess. I have used them and have been misled. So when it comes down to the thinking, do we need right ventricular support? Is this patient going to develop right ventricular, need right ventricular support? This is what sometimes we relate. If you can find one of these, please let me know. I'll be glad to hire them in our service to help us determine are we going to get right ventricular failure. So we did a study in the US, and we went to INTERMAC, which is the national registry, and we looked for all the BiVAD patients who have been done, either with centrifugal pump bilateral BiVAD hardware or LVAD plus temporary RVAD. And what we found is that the majority of the patients are INTERMAX 1. INTERMAX relates to how sick the patient is. Intermax is a subclassification of the New York Functional Class 4 patient. It gives you more granularity to see who are the sickest patients. And we found out that the patients who get bypass are primarily Intermax 1 and Intermax 2 patients. When we look at their survival with the bypass hardware, we see at 6 months only 68% are alive. When we look at them, at the patients, if they had a bypass hardware or LVAD plus a temporary hardware, we saw there was not too much difference in the survival rate. However, when we look at the cannulation of the RVAD, all the LVADs were cannulated in the LV apex, the RVADs were either cannulated in the right atrium or the right ventricle. We saw slightly better survival with the right atrium. And there are many reasons for this. We can go into more detail. When we look at the competing outcome for bypass, when we look at the bypass hardware, 30% of the patients are dead within the first 6 months. And we get about 25% transplanted in the US. When we look at LVAD plus a temporary RVAD, still about the same number of patients do not survive. So he's telling us this might not be because of the device, this might be because of how sick these patients are who are Intermax 1 and 2 primarily. When we do a similar analysis utilizing the total artificial heart, 359 patients within Intermax, we see again in blue, most of the patients are Intermax 1 and 2, very sick patients. When we look at them to compare to the LVAD patient, we see that at least 82% of the patients who get a total artificial heart have some degree of biventricular failure as determined here. So the outcomes with the total artificial heart, 65% similar to the bypass. When we separate that by experience, we can see centers with more experience have a better outcome than centers with no experience, something that you expect. So in conclusion, tailor the device of the patient needs. We make the decision on what device the patient is going to need, bypass or LVAD in the operating room. The increased mortality appears to be secondary to the patient, not necessarily to the device. Can you use a bypass or a total artificial heart? Yes and no. There are some characteristics that are similar. What device should I use? Determine the physiology and the anatomy. What do you feel comfortable with? If you need more help, you can ask for assistance. Do what will give you the best outcome. Remember, you have to maintain a financially comfortable group. Tips for good outcome: correct patient selection, timing of intervention, correct device selection. It's okay to do a bypass or a TAH if you have to. Thank you very much.
Questions?
If I would ask you, right now you had a stable patient with biventricular failure. No specific indication of total artificial heart. No ruptured septum. Right. What would you prefer? Cardiac or bypass heart?
If it's a bridge to transplant and the patient, and I feel comfortable doing a bypass, I will do a bypass. A total artificial heart is when you really have to remove the heart. Post-infarction VSD, amyloid. A failed transplant with rejection, ongoing rejection. Patients with some congenital abnormality that you want to repair. So we'll remove the heart if we need to. Otherwise, we can do a bypass. The outcomes are about the same, and the outcomes will get better with time. Thank you.
Sorry, what's the stroke rate in the destination group?
The stroke rate depends on the device. Right now, I can tell you, with the HeartMate 3 seems to be better with the HeartMate 2, and the hardware has the worst from a few years ago, although it's getting better. So, number-wise, that's what you want. I just have them all combined, but I can tell you that they are expressed in events per 100 patients a month. So it's about 5 events per patient per 100 patients a month. So it's very low for LVAD, and hopefully that will get better with time.
Thank you.